in classes up to this point, we have discussed causes of trunk wounds: pressure, friction, shear, moisture. We have talked about how wounds heal. We have talked about wound assessment, and we've discussed the basic principles of wound management. In the next few classes, we are going to discuss specific pathology related to lower extremity wounds. Of course, we know that a lot of lower extremity wounds are actually due to pressure, shear, and friction, such as heel ulcers and some of the ulcers that occur over the ankle bones. But we also know that a number of lower extremity wounds are caused by underlying vascular disease, either arterial disease or venous disease, or by neuropathic changes, which are common in the diabetic patient. That's going to be the focus in these next few classes. And we're going to begin with lower extremity arterial disease and arterial ulcers. Now, when you think about lower extremity arterial disease and arterial ulcers, you want to think about the fact that the problem is with blood flow delivery to the tissues. There's damage to the arterial system. And we know that the whole job of the arterial system is to effectively deliver blood, oxygen, and nutrients to the tissues. So if there's damage to the arterial system, the problem is going to be not enough oxygen, not enough nutrients to the tissues. And the end result is going to be tissues that are chronically ischemic, chronically hypoxic, extremely vulnerable to injury. When the arterial disease is severe, you can get spontaneous necrosis of the distal tissues, typically found at the level of the toes. So let's back up and let's talk about the pathology of lower extremity arterial disease. We've already talked about the fact that when we talk about arterial ulcers and arterial disease, we're talking about the arterial side of the vascular system. And we know that the main job of the arterial side of the vascular system is to deliver oxygen and nutrients to the tissues. Now, what I want you to realize is you already know practically everything you need to know about lower extremity arterial disease because you know so much about coronary artery disease. And the pathology involved in lower extremity arterial disease, the pathology involved in coronary artery disease are exactly the same. The only difference, the vessels involved. So looking at the pathology, you're very familiar with these two factors that work together to cause coronary artery disease. You know that high levels of circulating lipids and nicotine byproducts can damage the vessel wall, and high levels of circulating lipids can lead to plaque deposits. So let's talk about each of those. We'll start with plaque deposits. When you have high levels of circulating lipids, those lipids are frequently deposited within the vessel wall. Then those plaques progressively enlarge and also progressively calcify. The end result is that the lumen of the vessel becomes narrower and narrower because of the plaque that's filling the lumen of the vessel. And the vessel wall becomes stiffer and stiffer because of the calcification process. At the same time, those high levels of circulating lipids and nicotine byproducts in patients who smoke cause damage to the endothelial lining. Injury causes inflammation and release of growth factors. Growth factors cause overproduction of the smooth muscle cells in the vessel wall. That further thickens the wall of the vessel, narrows the lumen. So what you end up with is a vessel with a much narrower lumen and a stiff vessel that is unable to respond to demands for increased oxygen. So let me give you an example. You think about what happens when you're sitting down. Let's say you're just watching TV, sitting there studying, whatever. The tissue demands for oxygen are pretty low at that point. So the vessels to the lower extremity are at least partially constricted. But let's say you get a commercial break And during this commercial, you want to go to the bathroom, you want to get something to eat, you want to get something to drink, you want to make one quick phone call or send a text or whatever. So you jump up and you start running around. Now, immediately, the tissue's metabolic rate increases and the demand for oxygen increases. And for you, no problem, because your vessels immediately dilate to increase blood flow to the tissues to meet the increased demands. You sit back down, oxygen demands drop, vessels go back to normal size. So throughout the day, the vessels in your legs constantly are changing diameter. They're increasing diameter when necessary to meet demands for increased oxygen, and they're constricting and reducing the diameter when the oxygen needs go down. But if you had lower extremity arterial disease, you would have vessels that were thickened with narrow lumens and with very stiff walls. And those vessels are much less able to respond to needs for increased oxygen. So what tends to happen is you get fixed rate blood flow. It might be enough as long as you're at rest. It's not going to be enough when you get up and start moving around and increasing the metabolic rate in the tissues. Now, the other thing that happens is that most of your patients with lower extremity arterial disease have other factors going on that make them higher risk to form small little clots, emboli, thrombi. This is particularly common if you look at your handout. You'll see it talks about patients who have elevated lipid levels, patients who have elevated homocysteine levels. Also, we know that patients who use tobacco, and especially smokers, are in a hypercoagulable state. So they're much more likely to form little clots that can get lodged in those narrow vessels and occlude the vessel and cause an acute ischemic episode. So to summarize, what's going on with lower extremity arterial disease? Plaque formation. The plaque narrows the vessel lumen. The plaques become progressively calcified, which makes the vessel wall stiff and less able to dilate when needed. At the same time, damage to the endothelial lining causes overproduction of the vascular smooth muscle cells that further thickens the vessel wall. High lipid levels, nicotine byproducts, other hypercoagulable states increase the risk that you'll form small clots or thrombi that can plug a narrow vessel. The end result is diminished blood flow at rest and inability to increase blood flow in response to demands. So let's look at the risk factors, and again, go back to coronary artery disease. You know these risk factors very well, and you see them listed here. They're the same risk factors. So smoking, a huge risk factor for coronary artery disease and a huge risk factor for lower extremity arterial disease, because nicotine can damage the endothelial lining. Nicotine increases the risk that you will make little clots that plug narrow vessels. And we also know that nicotine is a powerful vasoconstrictor. Diabetes, another huge risk factor. For those of you who work in outpatient wound centers, I'm betting that most of your patients with lower extremity arterial disease are both smokers and diabetic. Several things. Diabetes is associated with increased blood viscosity, increased risk of clot formation. Also, insulin is a growth factor. So patients who have type 2 diabetes and chronic hyperglycemia and chronic hyperinsulinemia, because the whole problem is insulin resistance, it's like the blood vessels are constantly exposed to growth factors that increase production of those vascular smooth muscle cells, thicken the vessel wall, narrow the lumen. Hyperlipidemia, we've already talked about hyperlipidemia. We know that lipids cause plaque formation. Lipids can damage the endothelial lining and start that whole inflammation, growth factor production, overproduction of the vascular smooth muscle cells. Hypertension, also a risk factor, though we're not exactly sure of the mechanism of injury. We do know that many of our patients who are hypertensive also have lower extremity arterial disease. Elevated homocysteine levels, this has been shown in a number of epidemiologic studies to be a risk factor for lower extremity arterial disease. So most vascular surgeons routinely check homocysteine levels. The good thing is, this is a genetic factor. So if you tend to have hyperhomocystinemia, it's going to be genetic, but it's easily treatable. As you see on your handout, you can treat it with vitamin B6, vitamin B12, and folic acid. Now, all of those are potentially reversible. Hopefully we can get our patients to stop smoking. Hopefully we can improve diabetes control, get their lipids under control, treat hyperhomocystinemia, treat hypertension. Age, not a reversible factor, but a significant risk factor. As you see on your handout, approximately 30% of individuals over the age of 66 have lower extremity arterial disease. When you think about what's happening with the demographics in our country, and you think about the aging of America, you know that we're going to have many, many more patients with lower extremity arterial disease and arterial ulcers. Obesity is a potentially reversible risk factor. Family history, not reversible, and a very significant risk factor. But the point is, most of these are reversible and controllable, and that's what we have to focus on. Now, if you look on your handout, I did want to just point out that recent research also shows a link between inflammatory conditions, for example, chlamydia, pneumonia, and other inflammatory infectious processes, autoimmune conditions, anything that increases inflammation in the body seems to be a risk factor for lower extremity arterial disease through mechanisms that are not totally clear. So it goes back to control all known reversible factors, treat infections promptly, manage autoimmune conditions, inflammatory states. Now I wanted to spend just a minute talking about the difference between diabetics with lower extremity arterial disease and non-diabetics with lower extremity arterial disease. I'm not going to ask you to list these. I just want you to be aware that diabetics are much higher risk for lower extremity arterial disease that involves multiple vessels, multiple segments of the same vessel. They're much higher risk for bilateral as opposed to unilateral disease. But here's what I want you to really pay most attention to, these last two things. Non-diabetics are much more likely to have disease affecting the vessels between the waist and the knees. These are the patients who come in and they have film pop bypasses, and they do well. But your diabetic patients are much more likely to have disease that involves the vessels between the knee and the ankle. So the perineal arteries, for example, are commonly involved in the diabetic patient. That means that diabetic patients in general are less amenable to bypass. It doesn't mean they can't be bypassed, but it means they always have to have a thorough vascular workup to see exactly which segments of the vessel are damaged. They have to make sure that the distal vessel is healthy so that there's something to bypass too. In addition, your diabetic population is also at risk for microvascular disease. So they can have both macrovascular and microvascular disease. Macrovascular disease is going to involve the arteries in the lower leg. Hopefully, macrovascular disease is amenable to bypass. Microvascular disease, in contrast, involves the smallest arterioles in the capillaries, and you can never bypass those. So you might have had a patient who had relatively warm feet, a palpable pedal pulse, and yet has necrotic areas on the toes. And you think, well, what's going on? Well, the larger vessels are open, but the smaller vessels are closed. And so you get pinpoint areas of necrosis as a result of the damage to the smallest vessels. So we always have to be aware in evaluating our diabetic patients that they are at risk for both macrovascular and microvascular disease. We pay attention to pulses and warmth, but we also have to look at the distal toes and the condition of the tissues at the distal toes. So as we said, with the diabetic patient, it's much more likely, they are much more likely to have involvement of both the mid-sized vessels and the small vessels. Now we're going to talk about indications of lower extremity arterial disease. What are the signs and symptoms? How do you know that that's what your patient has? Because they just come in and they say, I have this sore and it's not getting any better. And my leg hurts. And you have to figure out, does their leg hurt because of arterial disease, because of venous disease, because of neuropathic disease, because of some combination? What are you dealing with? So again, go back to what's the first indication for most patients that they have coronary artery disease. And for most patients, it's chest pain. With activity, they're not getting enough blood flow to the heart muscle. And ischemia to the heart muscle presents as chest pain, angina. What's your patient with lower extremity arterial disease going to complain of? Pain. Initially, they have pain only with significant activity. So they might say, oh, I'm fine as long as I'm just walking around the house or as long as I'm walking slowly through the mall. But if I have to move quickly, if I have to walk all the way from the parking deck to my office, I can't do it unless I stop and rest, stop and rest, stop and rest. Well, that makes sense, doesn't it? Because they've lost the ability to dilate their vessels, increase blood flow to the tissues during periods of increased need. So when they get out of their car and they start walking for a distance, right at first they're okay, but pretty quickly their tissues become oxygen hungry and those damaged vessels can't meet the need. Then their tissues hurt. That prompts them to stop or slow down, to reduce oxygen demands. When they reduce oxygen demands, the pain tends to go away. This is known as intermittent claudication. Pain with activity relieved by rest. Activity, pain, rest, relief. So when you're trying to decide if a patient has an arterial ulcer, or a venous ulcer, or a neuropathic ulcer, one of the most important questions you will ask is about pain pattern. Do they have pain? And if so, what makes it better? What makes it worse? The patient with arterial disease will always tell you, it's worse when I put my legs up, it's better when I put my legs down. It's worse when I get up and walk, it's better when I sit down and rest. So rest and dependency makes it better, activity and elevation makes it worse. Makes sense. What do we tell patients with angina? When they have chest pain, we tell them sit down, get quiet, rest. Because we're reducing the oxygen demands of the heart muscle. When the patient has intermittent claudication, sit down, rest, reduce the oxygen demands of the tissues. Now, eventually, they will progress to the point where they have nocturnal pain and then rest pain. Nocturnal pain occurs when they go to bed. Because when you go to bed and you put your legs out straight, you've lost the benefit of gravity. When you go to sleep, your cardiac output is diminished, and so they're not getting as much blood flow out to the tissue. So what you hear people saying is, well, I go to bed, but within 30 minutes, 45 minutes, I wake up with my legs hurting. And then I have to get up and I have to go get in my chair and I have to sleep all night with my legs down. Classic for a patient with arterial disease. And I have to tell you a funny story. I had a patient at the VA And when I was asking him, well, what makes your pain worse? Well, walking made it worse, and putting his legs up made it worse. What makes it better? Camel cigarettes. And I'm like, Camel cigarettes? And he's like, see, you don't believe me, nobody believes me. I'm like, well, that just doesn't make a lot of sense from what I know, but explain to me why you think that Camel cigarettes make you better. And he's like, well, I go to bed, and in about 30 to 45 minutes, I wake up and my legs are killing me. He's like, I sit up on the side of the bed and I light up my Camel, and within 3 drags, my pain's better. Well, of course it's better because he's sitting up on the side of the bed, and now he's got dependency to improve blood flow. But do you think I convinced him of that? Oh no, Camel's definitely got the credit. Eventually, they will have pain even at rest, even when they're sitting with their legs down. By the time that they get into rest pain, they typically have about 90% occlusion of the vessel. So that's a very advanced indicator. Most of our patients with lower extremity arterial disease are diabetic. That means that many of them have both arterial disease and neuropathic disease. Both arterial disease and neuropathic disease cause pain. How do you know what kind of pain they have? How do you do the differential assessment? And you go back and you ask them, what makes it better? What makes it worse? Arterial pain, better with rest and dependency, worse with activity and elevation. Neuropathic pain, on the other hand, is frequently improved by activity. So patients might tell you it's worse at night, it's burning, stinging, pinprick, pins and needles kind of pain. Some patients describe it as electric shock pain. And what makes it better is if I get up and I walk. I can walk it off. Why is that? Because you've got damaged nerve endings that are sending inappropriate messages to the brain. But when you bombard those nerve endings with other types of signals, you can drown out those painful signals. So a patient with arterial disease would never tell you that they walked it off. Walking would always make it worse. So if they walk it off, that's an indication that it's neuropathic pain. Okay, the next thing you look for is indications of chronic tissue ischemia. Indications that the skin, the hair follicles, the nail bed is not getting enough blood flow to replace the skin cells at a normal rate, to replace hair at a normal rate, to replace nail cells at a normal rate. So what do we typically see in a patient with arterial disease? Thin, shiny skin that looks like anything could cause a break in the skin. What about hair growth? You're going to see a marked reduction in hair growth because it takes blood flow to grow hair. Now, when you're looking at a patient, you're looking to see, is there any evidence of hair on the lower extremities and the feet? If you see somebody with hairy toes, that is a great sign. It might not be sexy, but it's really, really healthy to have hairy toes because it tells you they're getting enough blood flow to their toes to grow hair. A great sign. What if they have no hair? You don't want to automatically assume that they have lower extremity arterial disease because some patients have never had much hair. So what you're really looking for is a major change. If you have somebody with no hair or very minimal hair on the lower extremity, you want to say, I see you have very little hair on your leg, on your foot. Is that different? Has it always been that way for you, or is this a change? For women, of course, you have to find out if they're shaving. And what about nails? Well, you think about the fact that if you're not getting enough blood flow to the nail bed, you're going to have very thin nails. And they typically will have these little ridges in the nail. The problem is that many patients who have lower extremity arterial disease also have fungal nail infections. And fungal nail infections make the nail thick, yellow, discolored. So if you see evidence of a fungal nail infection, what you know is that you cannot use the nails as an indicator of perfusion, because any thinning of the nail is going to be masked by the thickening that occurs in response to the fungal infection. So what do we always look for? Thin, shiny skin, changes in hair growth. And you may be able to use the nails as an indicator, but only in patients who do not have fungal infections. The next thing we look for is color changes. So we look for the color in the lower extremities, the legs and the feet at rest. We look to see what happens when we put the legs up, and we look to see what happens when we put the legs down. Now, if you have somebody who has normal perfusion, all of you I'm thinking, if you're lying on the couch and then you elevate your leg, you'll see no change in color. If you sit up and you put your leg down, no change in color, because you have healthy blood vessels and they respond rapidly. You put the leg up, they dilate. You put the leg down, they partially constrict. And color remains the same. But if you have a patient with lower extremity arterial disease and damaged vessels that cannot meet the tissue's needs for oxygen, when you put the leg up, now you've added elevation to an already compromised system. And what you're going to see is marked pallor in a patient with bare skin and a gray, ashen, or cyanotic tone in patients with dark skin. When you put the leg down, the vessels remain dilated. They're chronically dilated, trying to meet the tissue's needs for oxygen. And so you get what we call dependent rubor, that kind of purple-red discoloration from mid-calf down that occurs in patients with lower extremity arterial disease when they have their legs down. So you can see here dependent rubor, elevational pallor. You'll also get temperature changes, but that's not nearly as significant because a lot of people have cold feet, even though their perfusion is absolutely normal. Now, another test we do is venous filling time. And we'll have you do this when you come on site, but you can practice it at home. What you do at the venous filling time, let's say you're lying on the couch. Now you put your leg up and you hold your leg up until all of the veins in your foot collapse, till you can't see the veins anymore. And then you sit up, you put your legs down, and you count the number of seconds it takes for the veins to refill. And think about the fact that once you drain all the blood out of the veins, they're going to gradually refill from the arterial side of the capillary bed. If you have normal perfusion, they'll refill pretty quickly. But if you have compromised perfusion, they're going to refill much more slowly. And as you see on your handout, venous filling time that's more than 20 seconds is indicative of significant arterial disease. Capillary refill, you can do that. Again, remember that a lot of your patients will have thickened nails or they'll have polished nails, so we frequently end up using the toe pad to check capillary refill, and of course it should be less than 2 to 3 seconds. But it's not as significant a finding as prolonged venous filling time. Then, of course, you're going to check pulses. You're going to check the dorsalis pedis, which typically runs between the first and second toe along the arch of the foot, so right along here. And then you're going to check the posterior tibialis, which runs right behind and above the medial malleolus. So you're always feeling on the inside of the leg. So you check both the dorsalis pedis and the posterior tibialis. You're checking to see, do the pulses feel normal when you palpate them? Do you have normal pulses? Or do they seem very diminished? Or are they non-palpable? If they're non-palpable, of course, you're going to see if you can hear them with the Doppler, if you can auscultate the pulse. Now, on your handout, you will see that there are some individuals who have perfectly normal perfusion, but you cannot palpate the dorsalis pedis. And it's usually just because anatomically the vessel is located deep in the tissue and it's just very difficult to palpate at the surface. I know a lot of you have tried to palpate the dorsalis in a patient with marked edema and been unable to do so. So if all of your other findings are normal, you have a normal posterior tibialis, but you can't palpate the dorsalis, not necessarily significant. Probably the most objective indicator of adequate versus compromised perfusion is your ankle brachial index. And what you're doing with ankle brachial index is exactly what it says. You're comparing ankle pressures to arm pressures or brachial pressures. So if you see on your handout, and let's just go to the next slide. Here's the procedure for doing an accurate ankle brachial index, and you will do this on site because this is a very important test to know how to do accurately. First of all, you want the patient to rest quietly in the supine position for about 10 minutes. Ideally, you make sure they have not had exposure to nicotine, to caffeine. So you've got them resting quietly. Now you're going to take the brachial pressure in both the right arm and the left arm, but you are not going to use the stethoscope, the standard stethoscope. You're going to use your Doppler. Why? Because if we're using a Doppler to get our pressures in the legs, we need to use a Doppler to get the pressures in the arms because Dopplers are more sensitive. And so we should be using exactly the same instrument to measure arm pressures and ankle pressures. So I'm lying quietly. You're going to get my right brachial, my left brachial. Then you go back here, you can see how you put the cuff around the lower leg about 1 inch above the malleolus. You find the dorsalis pedis. You use your Doppler to get the systolic pressure in the dorsalis pedis. You rotate your cuff. You find your posterior tibialis. You use your Doppler to get the systolic pressure in your posterior tibialis. We will practice calculation on site. This is critical for you to do correctly. If you reverse your numbers, your values will be totally wrong and will take you in the wrong direction. What I always remember is A comes before B. So when I'm entering into the calculator, I first enter my ankle pressure, the highest of the two ankle pressures on the right. So let's say that on the right, my dorsalis pedis was 60 and my posterior tibialis was 54. So I'm going to enter 60 divided by, and then I'm going to look at my two brachial pressures. I'm going to take the highest of the two brachial pressures. So let's say that my right brachial was 116 and my left brachial was 120. So I'm going to take 120. I've got 60 divided by 120. And that's going to give me a 0.5. Now you see how important it is to enter the numbers correctly, because if I reversed it and I said 120 divided by 60, I get 2.0. Very different than 0.5. Okay. So now let's look at interpretation. What's normal? Well, you're comparing pressures in the leg to pressures in the arm. If the system is healthy, leg pressures, arm pressures are going to be very similar. So the closer your number is to 1.0, the better. If my arm pressure is 120 and my ankle pressure is 118, very close to 1, that's great. The farther you get away from 1, the more significant that is in a negative way. So in the example I gave you, it was 60 divided by 120. Well, you can immediately think 60, that's half of 120. That's not good. Right, that's not good. So normal is 0.9 to 1.3. Once you drop below 0.9, you have some degree of lower extremity arterial disease. Okay, you're out of the range of normal. If it's less than 0.9, but it's greater than 0.6, it's mild to moderate disease. However, anytime you have any degree of lower extremity arterial disease, you almost definitely have some significant coronary artery disease as well. And based on this, there's a push to encourage primary care physicians, family nurse practitioners, PAs, to use handheld Dopplers to check ABI in the office. And if they find a patient whose ABI is less than 0.9, the recommendation is that that patient be referred to cardiology for a workup. Because if I've got diminished blood flow to my legs, I've almost definitely got diminished blood flow to my heart. Now, 0.6 to 0.9, you do have diminished blood flow. This is moderate, mild to moderate disease, but notice you still retain the potential for healing and you would not develop arterial ulcers because you've still got better than 50% flow. As you move below 0.6, now you're moving into significant ischemia. These patients need a vascular consult. Once you get less than 0.3 to 0.4, so you're talking 30 to 40% of normal, this is considered critical ischemia. If it can't be corrected, that patient's probably going to end up with an amputation. So let's look at the other end. What if it's greater than 1.3? Is that really good? No. That means that the vessel walls are calcified, and you cannot effectively compress the vessel because of all the calcification in the vessel wall. And so it means that your ABI is meaningless, and that that patient has to be sent to the vascular lab for further workup. And that's actually pretty common in your diabetic patient to have some degree of calcification or significant calcification. So here's the rule of thumb. When do you send a patient for a vascular consult? Anytime their ABI is less than 0.6 and you're trying to get the wound to heal. Anytime your ABI is over 1.3 because your ABI means nothing. And also, anytime you have clinical indicators of significant ischemia. So you have a non-healing wound, you have pain at rest, you have significant pallor. Anything that signals that clinically there's a marked reduction in blood flow should prompt a vascular consult. Now, I'm not really going to ask you about toe brachial index or TCPO2 because those are typically done only in a vascular lab. They might ask you about this on the certification exam, so I'm going to go over it. Toe brachial index has been recommended as an alternative to ankle brachial index in a patient who has high ABI readings. So let's say I do the ABI and I get 1.4. Like, well, that doesn't mean anything because my vessels are calcified. It turns out that the vessels in the great toe are very, pretty resistant to calcification. So many times you can get an accurate reading in the great toe, even if you can't get an accurate reading at the level of the ankle. But it is so hard to do. You have these little tiny cuffs that you have to wrap around the great toe. You have to find the pulse and try to hold your little Doppler over the pulse while you pump it up. Very, very difficult to do. Studies done at the Medical University of South Carolina showed that toe brachial index readings obtained at the bedside were not valid. So all you have to know is if the patient's ABI is greater than 1.3, send them to the vascular lab. Now, if the vascular lab says, oh, their toe brachial index was less than, and it should say 0.7. If it said it's less than 0.7, the TBI will say 0.5, again, very significant. Or if the absolute toe pressure was less than 30. When you pumped it up and you're deflating the cuff and they said, oh, the systolic pressure in the toe was 20. Well, that's a very negative finding. So toe brachial index is sometimes done in the lab for patients who have elevated ABI readings because the toe vessels are less likely to be calcified. What do you have to know? Only that TBI is an alternative to ABI when the ABI levels are high due to calcification. That normal values are 0.7 or higher, or absolute pressures of 30 or higher. TCPO2 is being used more and more in vascular labs to evaluate both macrovascular and microvascular blood flow. When you think about it, ABI measures macrovascular, what's going on at the level of the posterior tibialis, the dorsalis venus. Those are mid-sized vessels. TCPO2 measures oxygen in the tissues. If you do TCPO2 at the level of the toe or the level of a non-healing wound, it's going to tell you how much oxygen is being delivered to the tissues. So you may have access to a lab that can do TCPO2 studies for you, and that can be very beneficial in actually determining how much oxygen is getting to the tissues. Now, as you see, TCPO2 levels less than 30 are considered indicative of significant disease and very poor potential for healing. When we talked about oxygen required for healing, the level of oxygen required for healing, we said normally it was going to be about 40 millimeters or higher. As you drop below 40, your potential for healing drops also. As you drop below 30, very unlikely that you will heal. So TCPO2 can be helpful. It's not a study that we typically do, so I'm not going to hold you responsible for that at this point. I want you to focus on the studies that you can do at the bedside. What can you do? You can certainly evaluate response to elevation, response to dependency. Is there elevation on power or cyanosis? Is there dependent rubric? You can certainly look at the skin, the hair, and the nails. You can do venous filling time and cap refill. You can check pulses and ABI. Those are the things I really want you to focus on. Okay, so we've talked about indications of arterial disease, and now we're going to talk about characteristics of arterial ulcers. This is going to be very important to you. We're going to come back to this in a later class and talk about differential assessment. Pain pattern is a critical aspect of differential assessment. We've already said for arterial ulcers, pain is going to be worse with elevation, worse with activity, relieved by rest and dependency. Okay, what are the other critical characteristics of arterial ulcers? Well, location is one. So you always pay attention to where is this ulcer located. Now think about the fact that arterial ulcers occur in response to a delivery failure. You're not delivering oxygen and nutrients to the tissue. And then think about the fact that the toes are at the most distal point from the original source, the heart. If there's going to be a spontaneous failure in the system, if you are going to develop spontaneous necrosis, it's almost always going to involve the toes or the distal foot, because that's the area furthest from the heart. And so some of you have seen patients who develop spontaneous necrosis of the toes, like you see here. The second toe is completely gangrenous, dry gangrene. And you have beginning involvement of the great toe, the third toe, the distal foot. That makes sense because that's the point at the greatest distance from the heart. So arterial ulcers are going to occur either distally, toes, or you may get an ulcer that began with a traumatic injury And because there was not enough blood flow to support healing and to control bacterial loads, that small traumatic injury turned into a large non-healing wound. That's what you see here. This patient has ulcers in the pre-tibial area of the leg. Patients come in, they bumped into the dishwasher door, they bumped into the coffee table, into their workbench, into the shower door, getting out of the shower. And they'll tell you it started out as a little tiny cut, and then it just got bigger and bigger and bigger. Yes, because they had just enough blood flow to maintain, but nowhere near enough blood flow to heal that small wound. So where do arterial ulcers occur? One of two sides, either distally or areas of traumatic injury that went from being a small laceration, a small cut, into a large open wound. The ulcer bed itself is either going to be pale or necrotic because what's the underlying pathology? Ischemia, not enough blood flow. They're going to have very minimal exudate because you have to have blood flow to make exudate. And typically the wound edges look more punched out, almost like a cookie cutter made them, although that is not the most significant finding. Now, another characteristic of ischemic ulcers is that they are frequently infected. In fact, I assume that arterial ulcers are infected until they prove me wrong. And why do I say that? Because you've got an open wound, you're always going to have colonization. You're always going to have bacteria on the surface of the wound. You have very low levels of blood flow, which means you do not have any white blood cells, and you have low levels of oxygen, which is what the white blood cells need to kill bacteria. So if you're not getting any white blood cells to the area, and the few white blood cells that are on site have inadequate amounts of oxygen, how are you going to control bacterial loads? You're not. So most arterial ulcers are infected, and you always have to be very alert to subtle indications of infection because an ischemic wound is very rarely going to show marked erythema, marked induration. Erythema, induration of vascular response. They have damage to the blood vessels. They can't mount a normal vascular response. So here's a patient. I actually got these slides from the American Diabetes Association. I got one of them turned around, and I apologize, I couldn't get it turned back around. It is the same foot. The patient came in, he had stepped on a tack or a piece of glass, he wasn't sure which. He had this wound that doesn't look great. I mean, it's got slough in the wound base, but it doesn't look terrible. However, when they took the cock-tipped applicator, there was undermining all the way around. It was fluctuant to the touch. There was slight erythema. So they did a CT scan to determine the level of tissue damage. And then they debrided based on the CT scan. And I want you to notice how much tissue was removed. So you have to be very, very alert to subtle indicators of infection. If you wait until it's bright red and hot, it's way too late. You're looking for very faint erythema, slight induration. Okay, so now let's talk about treatment. And we go back to, well, what's the underlying problem? Not enough blood flow. So what's the whole goal of treatment? Increase blood flow to the tissues. So our first thought is, let's get this patient into vascular. If I have a patient who comes in and their ABI reads are in the critical zone and they have an infected wound, the first person I want to talk to is the vascular surgeon. I want them to do a workup. I want them to determine, is this patient a candidate for revascularization? Because that's what I'm hoping, is that they can bypass that blocked area of the vessel and improve blood flow. Sometimes they can put in stents and maintain blood flow. That's going to be determined by the vascular surgeon. In addition, the vascular surgeon is going to look at medications that can improve perfusion to the extremities. Now, for many years, the drug of choice was Trental. and some of you may have heard of pentoxifylline or Trental being the drug of choice. That is no longer the drug of choice because multiple clinical studies show that it was very ineffective at safe doses. That to get any kind of therapeutic benefits, you had to give doses that were not safe, that were potentially toxic. So now the drug of choice is cilostazol or Platal, which has been shown in a number of studies to improve ABI, to reduce claudication pain, etc., etc. Statins to reduce lipid levels, and then possibly hyperbaric oxygen therapy. A lot of vascular surgeons consider revascularization and hyperbaric oxygen therapy to be stepped treatment. In other words, revascularize first, improve blood flow as much as possible, but then use hyperbaric oxygen therapy so that any plasmid that gets to the tissue is hyperoxygenated. So you go back to what we talked about when we talked about use of hyperbaric oxygen therapy. And what do we say? How does it work? Hyperoxygenates the plasma, so anywhere the plasma goes, oxygen goes. So the vascular surgeon may very well first do a revascularization procedure, place stents, whatever, and then send the patient for hyperbaric oxygen therapy. There are some limited studies that indicate that sequential compression devices may be helpful because they actually augment the normal circulatory cycle. You think about when the compression device inflates, it pushes all the venous blood back to the heart, and then the pump cycles off, all the pressure goes away, it invites arterial blood in. Cycles on, squeezes venous blood out, relaxes, arterial blood in. So it almost acts as a cardiac assist to push venous blood out, invite arterial blood in. Studies are ongoing. We'll know more about that within a few years. And then, of course, lifestyle modifications, very, very important. Most important, smoking cessation. Now, a lot of clinicians believe that, you know what, it doesn't do any good to talk to them. They're not going to stop smoking. But I bet a lot of you have worked with patients who have stopped smoking. We can't make their decision, but we have to make sure that their decision is based on current information. So we do want to talk to them. We want to say to them, this might be hard for you to hear, but I'm going to tell you anyway because you have a right to know. And then it's your decision what you do. The other thing we have to remember is that many times patients can do things short-term that they can't do long-term, or they don't think they can do long-term. So if I ask you to sign up to stop smoking for the rest of your life, you might be like, I can't do that. But if I ask you to stop smoking for 2 months till we get this wound healed, that might be something that you think you can do, especially if I provide you with patches or gum or medications and a support group to help you. So, do we owe it to our patients to have this discussion? Absolutely. Should we pursue short-term contracts? Absolutely. If the patient says, well, I tried to quit once before and it didn't work, you know what? The studies show that most patients have to try more than once before they're able to quit. We're there to help them, okay? Now, what about progressive walking programs? Progressive walking programs are very much like cardiac rehab. What you're doing is retraining the muscles to use oxygen efficiently and hopefully building some collateral circulation. But think about when we do cardiac rehab. Do we do it while the patient's in the midst of an MI? Do we say walk it off? Get on the treadmill, walk it off? Of course not. We wait until they're stable, and then we introduce cardiac rehab. Same thing with a severe arterial ulcer. We are first going to try to get the wound to heal because we don't want to compete with the wound for oxygen. So you basically keep the patient at rest while you try to get the wound to heal. then once you get the wound healed, that's when you begin the progressive walking program, which can be extremely effective. The other thing you'll see here is hydration. If you keep the patient well hydrated, it reduces blood viscosity, increases blood volume, and has been shown in studies to statistically improve tissue oxygen levels. So make sure your patients are well hydrated. Now, the other things you see on your handout, and you know them already, you want to treat your patient with lower extremity arterial disease just as carefully, if not more carefully, than you treat your diabetic patients. So what do you tell your diabetic patients about going barefoot? Don't go barefoot. Because if you go barefoot, you're higher risk to sustain trauma, which might not heal. Is that true of the patient with arterial disease? Absolutely. I learned from some home health nurses, teach patients to put on shin guards like soccer players wear when they're cleaning house, working in their workshop. Always wear shoes, hard-soled shoes. Always check water before you put your feet into it. Protect your shins. Do everything possible to prevent injury, because once you get a wound, it's going to be very hard to get that wound to heal. So we want a heavy focus on prevention. And that brings up something else for your female patients. Should they be going to the mall and getting pedicures? No. You're going to have to break up with the girl at the mall. What happens if she nicks them? You're not going to be able to heal that wound, and they're going to be very high risk for infection. So no pedicures for patients with lower extremity arterial disease. Their nail care should be done by a professional. Okay, I think we've talked about most of the things on your handout, so now I want to finish up by looking at topical therapy. Now, in determining topical therapy for any specific ulcer, these are the things you have to think about. Is the wound closed? Is it covered with eschar or covered with dry slough, or is it already open? If it's already open, you are forced to manage that wound like any open wound. You have lost the option to try to keep it closed, because it's not closed at the outset. So is it open or closed? Is it infected or non-infected? If it's non-infected, closed, and ischemic, you're going to leave it alone. But if it's infected, even if it's ischemic, even if it's closed, you're almost always forced to debride, to get rid of the necrotic tissue, to convert that closed wound into an open wound, because goal number one at that point is to eliminate infection. So think first, is it closed or is it open? If it's open, you already know you're going to proceed with standard topical therapy. Control your exudate, keep the surface moist, probably use an antimicrobial dressing, avoid trauma with removal. If it's closed, then you think, well, now I have to decide, should I leave it closed, or should I move ahead with debridement and convert that closed wound to an open wound? And how do you make that decision? Well, partially on the presence or absence of infection. So if it's a closed wound, non-infected, your first thought is, maybe I should leave this alone, at least until I check out perfusion. On the other hand, if it's a closed wound and it's infected, you know you have to move ahead, because your primary goal is to manage the bacteria and to prevent further tissue damage. And then the third thing you have to think about is level of perfusion. Is there enough blood flow to support healing? Is that your goal? What is your goal in wound care? Is your goal healing? Is your goal maintenance? Is your goal comfort? So if you have an open wound, we've already said, no decisions to be made in terms of leaving it closed versus moving ahead with debridement is already open. So here you're going to manage your exudate. Your goal is to maintain a moist surface. Almost always you'll use an antimicrobial dressing because that patient's very, very high risk for infection. But if your wound is closed, if it's covered with dry eschar, if it's uninfected, and it's poorly perfused, that's a situation when it's appropriate to paint with betadine and either leave it open to air or cover it with a dry dressing. Why paint it with betadine? To keep the bacterial counts low and to keep the eschar dry. This patient, actually the eschar had started lifting. We painted with betadine to keep it dry and to promote adherence. But if I have a wound that's closed and infected, even if it's poorly perfused, I am forced to move ahead with debridement. I cannot leave this wound because in this case, the necrotic tissue, the eschar, is serving as a food source for the bacteria. And my only chance of getting the bacteria under control are to eliminate the necrotic tissue in addition to treat with an antimicrobial systemically. So here you're going to aggressively treat the infection. You're going to debride, but you're going to debride non-instrumentally. No way would I take a scalpel to this, right? But could I apply Dakin-soaked gauze? Would that be compatible with my goals? Yes, because Dakins will dissolve the necrotic tissue and kill the bacteria. Okay, so I'm going to get the patient on antibiotics. I'm going to do conservative approach to debridement, non-instrumental approach to debridement like Dakin-soaked gauze. As soon as we get the patient stable, the infection under control, we're going to move that patient into a workup state so that we can determine, is this patient a candidate for revascularization? We're definitely going to keep hyperbaric oxygen therapy on the table as an option. We're going to hope that if the patient comes in with an infected necrotic wound, that we are able to control the infection, remove the necrotic tissue, determine that patient's candidacy for revascularization, follow revascularization with hyperbaric oxygen therapy if needed, or try hyperbaric oxygen therapy without revascularization if revascularization is not an option, and if baseline testing indicates that the patient may benefit. Okay. But what if that patient comes in, they have an infected wound with necrosis, studies indicate that there's no potential for revascularization, baseline studies indicate that there's no response to hyperbaric oxygen therapy. That patient is probably going to require amputation because there is not enough perfusion to support healing. So amputation is going to be required in patients with critical limb ischemia who are not candidates for revascularization and hyperbaric oxygen therapy, and sometimes indicated just for pain relief in patients with very severe lower extremity arterial disease, no potential for revascularization, and severe ischemic pain. For some of those patients, amputation can actually provide them with a lot of relief. Okay, we are going to stop there, and then our next session will be on venous ulcers, venous disease and venous ulcers, and differentiating venous edema from lymphedema. Thank you.